So first, it's Professor Ron Dagan. I will introduce him. He is a professor in Beer-Sheva Hospital, chief of pediatric department, and one of the best well-known researchers in the field of vaccine. And he will present you a global view on vaccination. It's not only a specific vaccine, a specific group, vaccination from which all the society, all the population benefits. Yes, Professor, please.
So, good afternoon or good morning. I don't know at what time everyone is waking up. But what I will represent is the way we now in Israel, I'm a part of the advisory board for vaccination, which is nominated by the Ministry of Health, but not necessarily Ministry of Health people. And how do we look now at vaccination? And I think this is a little bit of change of mindset from what many years was supposed to be vaccination, which is protection of the vaccinated person, to now understanding that vaccination is actually protection of the entire population, and how vaccinating people provide protection for the entire population. This is basically the idea of how we choose vaccines and which vaccine we choose in Israel to be part of the free of charge vaccination program. So I have too many stools here. Okay. I don't see that this moves. So if anybody can. No. This is always when you are first, you are learning for everybody else, okay? Okay. Okay. So what I show here is a sort of a schematic representation of the society. You see everything from babies to the elderly, and this is our society. When you look at our society, you understand that basically the society, what we tended to always think, these are individuals that live in society, sometimes in family, but actually the society all live with microorganisms, with infectious microorganisms, but also part of our flora. We all know that for every individual, 90% of the individuals is actually microbiological flora, only 10% are human cells. And so basically what we do in our society constantly, we move bacteria, viruses, parasites, fungi from one person to the other constantly in all directions. So every contact, I'm here with you in this hall, I'm giving you some of mine, you are giving some of yours. I kiss, I hug, I kiss the children. This is very important. So every intervention that we have on anybody will actually influence everybody else. And that is something that when you plan your public health, you have to understand that you are doing something for the entire society no matter what you choose. But this type of movement is not the same for every microorganism that you are fighting for. So here I just show a nice art, but actually what I show is different age groups, from infant to toddler to adolescents, young adults and elderly. And I show 3 bacteria against which we vaccinate. They are all encapsulated bacteria. They are all cause very bad invasive disease, and there is a lot of similarities between them. This is Haemophilus influenza B on the top, then it is pneumococcus, and then it is meningococcus. There is a lot of common. And they are all transmitted to people. But actually, when I look, first of all, they are not carried the same way. Usually, those are carried, the respiratory tract bugs, so they are carried either in the nose or in the throat or in both. But you can see that, for example, meningococcus is mainly carried in adolescents and young adults, while pneumococcus is carried mainly in toddlers, the same as Haemophilus influenza. So the biology is not the same, but even better than that, even more important than that, the main transmission without any vaccine is different. You can see that the Haemophilus influenza is mainly toddler to infants, the adults are usually spared. For pneumococcus, it's mainly toddler to infants, but both of them are very much carriage. And for meningococcus, it goes from adolescent and young adults to infants and young children. So if you want to intervene, you already know how to plan maybe your vaccines. It will not be the same planning. But this is the main transmission. You have also other secondary transmissions. And you can see, for example, the pneumococcus is the more complex because really the main transmission is here. But infants and toddlers transmit to all other ages. And of course, the elderly has a very high risk for pneumococcal disease. So if you want to understand a little bit how you act, I will choose the pneumococcus because it's the more complex and try to see how we reason in order to understand whether we need to vaccinate, which vaccine, and what is to be predicted. The other thing that is very important, we always used to look at what is our problem and what we give as a vaccine. Now we understand that those bacteria that are very dangerous are now often part of our normal flora. So we don't need to only see what is the problem now. But when we introduce the vaccine, what type of problems we are going to solve, what type of problems we are going to create by changing the flora. And this has to be leading to you, not what the problem is now, but using vaccine A or B or C, what will be the picture in 5 years after you start the introduction. So it's a little bit more complex. It needs more expertise, and this is why a lot of people are not doing the right decisions. But it needs to actually change into what are we doing to the society and how are we changing the society with the vaccine. So here is the pneumococcus. Pneumococcus can cause invasive disease. It enters into the blood. It causes meningitis, sepsis. It can go into the middle ear, cause otitis. It can be aspirated into the lung, cause pneumonia. Or those are called mucosal disease. But also because it's in the nose all the time, it is seeing all the time antibiotics, and we are over-treating with antibiotics. Israel and Romania are some of the champions of antibiotic use, and therefore the pneumococci become very resistant before they start to transfer, especially because they are in children, and children are getting all these antibiotics. So this is, the vaccine has to solve all this. But the common thing is the nose. The pneumococcus is in the nose, and from there it goes to the other places, but also to other people, but also into the body. So this is the source of entry, but even more important, in the source of distribution. Usually when I teach my students, I ask them, what do they see when they see this baby? And they say, oh, a cute baby, healthy, cute baby. So you're wrong. This is the classical bioterrorist. This is the guy who brings all the bad guys to everybody else, especially if that guy is going to daycare center or has a lot of brothers and sisters. So if a vaccine can reduce those bugs and reduce the transmission, that is the main role in the vaccine in bacteria that go from babies to everybody else, because as I will show you, there are much more cases that are not the babies, but you can prevent by giving the vaccine to the babies. So we call it indirect or herd protection, and that is actually how much you really save in the community by vaccinating the children. You protect the children, but whom do you protect more? So this is just to show you, in Israel we've introduced one vaccine, and then a more advanced vaccine for pneumococcus. And what you can see very clearly that we have reduced the invasive disease by 66% in young children. We reduced the complexity of otitis media that needs special treatment. We reduced pneumonias. Very successful program, but this is in children. We needed to know what also we get to the others and how much one vaccine or the other prevents the other people from getting problems. So when we look at which vaccine we are choosing, it has to be a safe vaccine, it has to be an efficacious vaccine, but it also has to reduce the transmission and also has to cover as many organisms as possible. If we go for example, for pneumococcus or meningococcus, you have several strains, so the vaccine that covers most of the strains that cause disease is better than a vaccine that covers less strains, of course. So in pneumococcus, we had at the beginning, the history was starting with 7 serotypes, and now we have actually 2 vaccines, either with 10 or with 13, and I will come back to it, but we are extending the serotypes to cover more strains. So the next question after safe and efficacious is how much do I really reduce the carriage and the spread of this organism? So again, schematically, this is the same society I showed you before. This in red are the children that actually are getting the vaccine through the active program. in yellow below are the children under 6 months that even if they aren't good in the program, they did not yet reach to get the vaccine, so they need to be protected, and they are most vulnerable because they are neonates. And then all the others up to 90 years and more. And 85% of all pneumococcal diseases are not in the red section, are actually in the yellow section. In the elderly, in the old people, in the young people, in the parents, and in the very young babies. So this is the vaccine. This is all what the vaccine can do. If I only check what the vaccine can do and compare vaccines, I am in trouble because I did not look at how much protection I get for the rest of the population, and I might miss one vaccine that makes better results than the other. So here is the result in Israel of carriage in the nasopharynx, in the nose, of introduction of the vaccine, first the 7-valent and then the 13-valent, which we are using. And this is children that come to emergency room. We take every day 8 children, so we have continuous hundreds per month, per month, and this is actually what we see. Each colon is 6 months. And the colored one, not the yellow one, the colored one are the vaccines that are in the type in the vaccine, and you can see how they are gradually or fastly reduced. Each one is 6 months to actually see here. So if my grandmother kissed me here, this is what she got. If I kiss my granddaughter, this is what I get. So my granddaughter is safer to me than I was to my grandmother, clearly, okay? This is important. This is the effect of how you protect the others. And this is 85% reduction, which means the vaccine was preventing the children to transmit. But this is nice. This is a story. What is the evidence? You talked about evidence. This is the evidence. We're having a very thorough, prospective, active surveillance in Israel. Israel is a relatively small country. We have only 27 hospitals that do cultures of bacteria, of blood and CSF. So you can actually look very carefully, and you actually know that this was the rate when we started in adults. This is 18 years and above. And you see that the disease caused by the vaccine types is reduced by 70%. So children in the nose, 85 less, 70% less. There were some expansions of the others, but altogether there is a 28% reduction. Now remember, 85% of the disease in the community, so we calculated very clearly. So for every child we protected, we have 3.3 adults in whom we prevent the disease. So it's actually 4 for 1. If you don't look at this, you have the wrong idea. So if one vaccine gets you less an effect on carriage, you are going to prevent maybe similar number in children, but much less number in adults. And adults is me and us here. I'm the grandfather, maybe some of you are the fathers or mothers. I'm protected by this. I'm protected for my granddaughter. It's nice. Then, of course, how many serotypes, or in this case, or how many strains in other cases can I use? Is it the same? Especially that some people think that you may have some similarities. This is serotypes in the new vaccine here, which are actually similar to those. Do we get exactly the same or not? I'm not going to, most of you are not pneumococcal professionals, so I'm not going to go in details. But it's important to get the best immune response specifically for the serotype, and that is something I'm not going to make you too tired with. But this is Romania, and this is the vaccine serotypes that are in PCV7, in the 7-valent or 10-valent, and these two are the ones in the 13-valent. And this is the percentage of those cases that cause multi-drug resistant, multi-antibiotic resistant, that's resistant to almost all antibiotics we are using in the community. So one of the things in Romania, as you know, Romania is a real champion in resistance. Actually, most of the first resistant pneumococci that were described were in Iași, in Romania, okay? And when we get strains from Romania to our lab, the microbiology people call me and they say something is wrong about our reagents, like okay, it's not. It's just high resistant. And you look at this. This is what the vaccine can do if you have all the strains reduced. This is just to show you that if you have the two vaccines, one that has cross protection, the other one that has full protection with the antigen, you have different antibodies. You can see definitely that the blue is much higher than the yellow, and it does affect the carriage and the spread. So what you actually can see that in children, in countries that use, for this 19A, which is the bad one, the multi-resistant, the invasive, the carried, etc., you can see that Israel, USA, and UK reduced the disease in children, the invasive disease in children, once the PCV13 was introduced, while the 3 countries using the cross protection did not see it. But even more, the adults, as I said, is the most important because they have more disease. And you look at, and this is completely the results of what you do in the nose, and you see reduction in one set of countries and increase in the other set of countries. So this is the leading things in Israel. You're looking at those points, and you make decision according to what is done all over society, and you add everything together. And this is just talking about invasive disease, but just to show you this as an example. And then you remember that there is a dynamic. Don't look at here. This is Colombia. This is when they introduced the vaccine without the 19A and the 6A and 3. Okay, this is the point, before they introduced the 7-valent. Introduction brought to the increase in cases in the absent in the vaccine, because now you increase the carriage and the spread to the point where those 3 now are the majority, the great majority in children and 40% in all ages. And then if you look at the overall, all the strains together, you can see a difference, and this is what conducted Israel last year to make a decision to continue with this and not to go to any other vaccine. We have a beautiful reduction in the parents' age, in the grandparents' age, and Finland is one example of a country that uses PCV10 with a very good vaccination rate and very good surveillance. I have a less reduction here and actually increase in the elderly. This can be seen in other countries too, mostly the same type of things. So we definitely believe that the vaccines are all safe, the vaccines are all efficacious, but when you choose which one, in addition to safe and efficacious, you have to look at the carriage, at the protection of the entire society as a principle, and then how many strains you can cover. And this is what conducted our country in Israel to choose a vaccine scientifically as the one vaccine that fits us, and we convey this to the Ministry of Health. And in Israel, if you have a complete recommendation from the scientific advisory board that is nominated by the Ministry of Health, you can take this advice. If the advice is this is the vaccine that fits us, you can go and start direct negotiation, and this is what we do. So, and we renewed this vaccine. So I did not come here to talk to you about this vaccine or the other vaccine. I just gave you an example of how now we discuss the entire population, we discuss the dynamic, we discuss what we learn from other countries, from other implementation, and we, above all, we take no-stop projects to get the data to see whether we were right or not, and the discussion before us, people stated going from whatever to evidence-based. Evidence is also something that can be looked in various ways. Just ask Mr. Trump. He will tell you how he looks at the evidence. But evidence like with data like this are driving us to decide whether we're doing the right thing or wrong thing, but we have to look at the entire society. Thank you.
Thank you very much, Professor, for this very interesting, very comprehensive presentation regarding vaccination. So vaccination reduces illness, carriage, but impact on the whole population. And it's able not only to avoid antimicrobial resistance, but also to make resources to concentrate on other fields. So prevention, vaccination as a major prevention activity may be the most cost-effective measure we can take, but also others should be developed. I will ask Professor Dafin Mureșan from University of Medicine and Pharmacy from Cluj to present you also a case, like a study case. We have the first one was immunization. The second one is stroke. not only from the point of view of treatment, but also in terms of prevention and rehabilitation of the patients with such illness. Professor, please.
Thank you very much. I will switch to a non-transmittable topic, which is stroke. But before all, I would like very much to thank those who invited me. I would like to thank a lot our President Joanna for this great opportunity and for organizing this, and to my very good friend and eminent Professor Afila, who is doing great generally, but particularly for this meeting he did a lot. So what I'll do in the next 15 minutes or so is to lead you behind the curtain of the latest developments in prevention, from prevention to rehab in stroke. As you may know, stroke is one of the most devastating conditions, and we have to face this. It's a big challenge, and at least for Romania, I would describe it as a disaster, because we haven't been able to control this in the last decade, let's say. Many advances have been done in Europe in the last decade. I will just mention the fantastic development that Austria did, installing and making function for a good, trying to create a functional system, having 57 stroke units for an 8 million population, which is amazing, and you will see the difference. Now, I will just start mentioning that basically we are dealing with a terrible condition, which is the second cause of death, the second cause of disability, and at the end of the day, almost 75% of our patients will get a disability after some time. I mean, this is related to the survivors. And these figures are very much related to Europe, because as you may see here, stroke is ranking second position in respect to dailies, disability adjusted of life years, and this is basically the combination between years lived with a disability and years of life lost. So this is a very good parameter, and this is the current situation in European region. Globally, stroke is ranking 6th, which is also very bad, but within Europe we are doing not so well, as I mentioned. Actually, Romania is somewhere at the end of the list in respect to stroke positive developments in the last 5 to 10 years. Anyhow, despite all this, we have to mention that since 2014 we are doing much better. I would say a robust program have been initiated, and now we have already 10 stroke units in Romania, but this is absolutely insufficient taking in consideration the population that we have to manage and considering the developments that other countries did. Now, treating stroke is not easy, so this is a typical model of how can we integrate treatment and healthcare. We have to start from primary prevention. This is a complicated topic. It's, I would say, it's still a very hot topic, but I will not insist on that. This is very much related to lifestyle. What we can do, and what we have done since 2014 particularly, is that acute stroke treatment have been improving in Romania. We have now, as I mentioned, the stroke units. Many advances have been done in the last decade, in particular in relation with mechanical thrombectomy. IV TPA, IV thrombolysis is the gold standard so far, but it's getting more and more clear that this mechanical thrombectomy is doing great. The last 6 very important trials that have been developed and already communicated will totally change the strategy in treating acute ischemic stroke, at least. We estimate this will be available, let's say, in the next 5 to 10 years, the new strategies. Secondary prevention, it's also a very important part. In this respect, we are doing better in Romania. We have a good, possibility to supply correct drugs in the correct strategies with the correct guidelines. Surgical part, it's not so sound in our country, but this is also an important therapeutic asset. And I would pay a special attention to rehabilitation. Rehabilitation, particularly for neurological disorders, is one of the most important therapeutic assets. In our armamentarium, neuro-rehab, it's very, very important because it's one of the most multimodal intervention. And many disorders, neurological disorders, can be treated, and a lot of disabilities will improve with the correct, diligent, and scientific delivered rehabilitation. We are doing also not so well in this respect, and we are looking at rehab today not only from the perspective of a motor deficit, but we are very much looking from the perspective of cognitive problems. So therefore, I think the major intervention that should be improved are here. The number of stroke units in Romania and also the number of rehab, and to create the correct link and the correct bridge. You will see further on that this is so important. Why? I will try to give you a definition. This is the definition of our president of the World Federation of Neuro Rehab, David Good, and I like always to say this is the definition of David Good in his transition to David Best, because he's a fantastic guy. So rehab is a process through which each disabled person will reach and will get back the maximum physical, functional, cognitive, and psychosocial recovery within two parameters: the lesion, the limit of disability, and on the other hand, there is another important part and concept is the biological reserve. So in this respect, as you may see, this is a very personalized issue. So rehab, it's not a standard, it's not very much a kind of evidence-based field. It's a very personalized field. So therefore, rehab needs a lot of evidence-based, but also evidence-based needs a lot of developments from rehab point of view. As we have to balance tremendously in the field of rehab between personalized medicine and evidence-based. So stroke is one of the most eligible conditions for rehab, beside all this long list of disorders that we know. And I would like, this is very important part, I would like just to highlight the difference between, the majority of us are medical doctors. We have been educated in a certain way. We have developed a certain mindset. This is the medical mindset with the medical model. This medical model is not matching 100% the rehab model for very good reasons. Why? Because look, the medical model focus on illness. You have here a meningococc, you have here a pneumococc. This is very clear. You have, let's say, an enemy. You have to, it's a friend and enemy at the same time, but you have to deal with this. And, okay, we may call it a disease. So it's focused on illness with a heavy reliance on evidence-based medicine and randomized controlled trials and the whole evidence-based hierarchical structure. On the other hand, in rehab, we are not dealing with illness. We are dealing with the disability. And we have to concentrate not on evidence-based only, but also on personalized aspect due to biological reserve, the magnitude of the lesion. There are many things to be evaluated. So we have to contemplate this. In the medical model, we are very much used to specific treatments. We have to have guidelines, medication, bang. Here, not. We have to focus on individual needs. We have to use an interdisciplinary team approach, and therefore we have to match these two models. Otherwise, it's complicated. It's very much complicated. So, as rehab, it's a very important part to be developed and a very important therapeutic asset. We have to concentrate and to incorporate this mindset. So I will not insist on that, but I would rather mention how this team should work and how should this team look like. Neurologists should coordinate a very complex team with a lot of partners in a lot of disciplines that are intermingling in order to deliver a correct motor, cognitive, and mood rehab. So the combination should be always. You know, now in the 21st century, for a certain patient, is not important if that patient will be able just to move from one part to another, one side to another. It's very important how that patient will feel like and how capable will be to understand the environment. Because without these parameters of quality of life, there is, no major gain. So, starting from the first, most important part that can be improved here, and I mentioned is the stroke unit, organized stroke unit. What is a stroke unit? Stroke unit, it's the best place to treat stroke patient, and I would mention that should be the only place where stroke patients are treated, and you will see why it should be the only place. You will see further on. This is a dedicated ward where a multidisciplinary team coordinated by a neurologist, including specialists, nursing staff, and the whole team that I have mentioned should treat stroke patients. We have different types of stroke units, of course. We have acute stroke units with an intensive, semi-intensive, or non-intensive model. I will not insist too much. We have rehab stroke units that accept patients, usually after 7-8 days after stroke. And we have comprehensive stroke units combining acute and rehab. That is the best. This is the best model. And in Europe, basically, European Stroke Organization has a special program to assess and to give licenses in all over the Europe for comprehensive stroke units, which is very important. The target therapy here is to reduce case fatality, disability, need for institutionalization, and we have evidence-based, very clear evidence-based, that doing treatment and having a good management of stroke patient in a stroke unit, this is superior to any other place in a healthcare system. So managing patients in a stroke unit will create an improvement in many respects. So that was lower, long-term institutionalization care was lower, dependency was lower. This is very much evidence-based and demonstrated. And usually, I like very much this slide. The magnitude of therapeutic effect just treating a patient in a stroke unit will give us a power of intervention, a therapeutic intervention of 4 or 5.6 reduction in all deaths and dependencies. And this is very important because look, thrombolysis, which is the gold standard, the best, will be able to reduce with 6.3. You see the magnitude and the importance of a stroke unit just by treating correctly the patient in the correct place, by the correct group, by good specialists, knowledgeable, will be able to reduce this with this magnitude. Aspirin, for example, will create an improvement of 1.2%. So if you add all these figures, these numbers, we'll see that altogether we can save 131 because we have 13.1%, so 131 lives out of 1,000 strokes. And if we look into the secondary stroke prevention, if we add the magnitude of the intervention of antihypertensive, smoking, cholesterol lowering, antiplatelet, anticoagulants, and carotid endarterectomy, we'll see that we can gain more 225 patients out of 1,000, and if we add this, we have 356 out of 1,000. What does it mean? This is more than 1 out of 3 strokes. So by doing correctly things, we can save 1 out of 3 strokes, which is fantastic. Actually, we are not in this capacity today, and I will close my presentation telling you that rehab will enormously reduce the disability and will increase the quality of life of our patients, of survivors, stroke survivors. And we have to look at rehabilitation as a very sequential process. We have the acute phase rehabilitation, we have the subacute phase rehabilitation. In the acute phase, the main objectives are to prevent the disuse syndrome and to create more and more independence of the self-care of our patient. In subacute phase, we need to stabilize a bit the achievements in the acute phase, and we have to increase the capacity of recovery and particularly locomotion and communication to the best of patient condition. In chronic phase of rehabilitation, we have to really stabilize patient for a long term and to reintegrate in all respects the patient in the society, to give him a good quality of life and to be able to come back to usual activities of daily living. Now, what would be the best model of rehab? And I think this is the message. The integrated healthcare system should deliver absolutely good services from the acute phase, acute neurological department with neuro rehabilitation unit, because the complete, the comprehensive stroke unit consists of the acute part and the immediate rehabilitation part. So we have to move patients, our patients, from the first days of stroke. Of course, we have to be very knowledgeable not to move those patients that are not stable, biological stable. That is very important. So therefore, it's very difficult to have a very, large evidence-based data. We have a study, we'll call it the AVERT study. The AVERT study proved that it's not so appropriate to put all the patients in the same program. Because, evidence-based is very much, in evidence-based is very much about reducing heterogeneity. We have to reduce heterogeneity, and then we have to create, very balanced groups. But it's very difficult here because you have individualized decision. So therefore, what we need this large number of stroke units. We need this neurorehabilitation work department where we can transfer, we have to discharge the patients from the acute part to this neuro rehab, hospital-based, could be also not an inpatient structure, could be also an outpatient structure for those who are eligible. But further on, we need, for some patients, hospital-based outpatient rehab centers, and what we don't have at all is community-based rehab centers. And I know there are good specialists here looking forward to develop many, many new therapeutic resources and to try to bring all stakeholders together, and particularly to involve these local communities to develop stroke rehab centers. And of course, some patients will go back home, will discharge these patients back home, and we also need somebody to continue with rehab there. So we need some mobile teams. So that would be a good, very brief scheme related to the future design for a good public neurorehabilitation and acute treatment for stroke patients. So thank you very much, and I would like just to mention that there are clear guidelines in this respect. The Japanese are most developed guys, in this respect, and they were able to have the best top organization in this respect, and to have also guidelines to evaluate the magnitude of intervention based on the grade system. Maybe you are familiar with the grade system, which is very much appreciated as a very good tool to assess the magnitude of intervention and efficacy and safety. Thank you very much.
Thank you very much, Professor Mureșan. Stroke as a model of good practices from prevention to treatment and rehabilitation. I think it should be in our attention, and we should note that are we prepared and we have resources to develop acute care centers, to develop rehabilitation center, and not only on money, but also in qualified workforce. And I think the key point in many of our problems, it's here to have qualified workforce specialized in the field of health. Otherwise, all these problems will remain on the paper, and only primary prevention will be available for many of public health issues. We discussed earlier regarding cancer, how far, how distance influence the chances of a patient to be discovered for cancer. And I understood that every 25 kilometers he have a superior degree of complexity of the cancer. And I think the same questions we can put to the stroke, how far he is from the stroke unit, and which are his chances to survive and to have a life, acceptable life, or a good quality life after that. So I want to introduce Dr. Professor Oliver Gröne from Germany. Maybe he will shortly introduce himself, and to see, and I wait this presentation because he can offer to us a model how we can integrate care and to, including for society like ours, to best use it, to use our resources in the best ways. Please, Professor.
Yes, thank you for the opportunity to speak here today. As you can see, I'm wearing different hats. I used to work in academia, and I still do, as a quality of care researcher. And I had a team in the UK responsible for analyzing the performance of NHS trusts, the hospitals. And year on year, we published reports on comparative outcomes, risk adjustment, all the tricks, and gave recommendations for trusts on how they could improve the outcomes. And mostly these recommendations were targeted not at what's happening within the hospital, but rather what's happening before and after. Referral and discharge mechanisms, community care, and follow-up care. And I got a bit frustrated that year on year nothing was happening, because simply there was no one in charge of that system. You have people in charge of the high-level system, NHS England, ministries, you have people in charge of hospitals and primary care clinics, but at the regional level, I would raise the question to us all here, who is in charge, and I will tell you an approach that we have implemented in Germany and in some other countries that try to bring the population focus at the regional system to the forefront. So I will focus on health systems. We talked a lot about drugs this morning, which are clearly necessary to conduct medicine. We talked about clinical medicine, which is also very important, but what's happening in the whole health system? How are we organizing the services in a way to get the biggest outcome? How do we create the best value? And I would argue that all health systems I've seen all over the world are fragmented. They grew around the paradigm of an acute hospital some 50 years ago, and then added a bit of community, primary, secondary, and whatever tertiary care to that. It's becoming increasingly complex, but the health systems are not designed around the current needs of chronically ill patients. So we're focusing too much on repairing someone once he has a stroke or another condition, a cardiac failure maybe, but we don't focus sufficiently on maintenance, prevention, health gain. So this is a slide I got from Professor Nelson, who came to visit us last year. It's a pathway within a hospital. Amy got breast cancer. Each of the boxes here is a microsystem. Now you might have heard about the microsystem approach from Dartmouth Health System. Microsystems are small clinical systems, 5 to 7 professionals, doctors working together with others. And these microsystems are usually what the professionals organize best. This is where they have responsibility, control, and a lot of the quality improvement actually has focused on microsystems. Now, but if you look at this pathway for breast cancer, you can see I can't read it from here, you can't either, but each color represents a different function. I think green is the medical oncologist, you've got surgery here, you've got red, which is a lab, you've got all kinds of functions. And so even if each of the boxes were perfectly organized, the question is, are we doing well enough to organize the whole pathway? And again, it's just a hospital. So that is, fortunately, Amy recovered. But to make it even more complicated or complex, we discuss health systems. Health systems is what is blue on this map. That's from another colleague in the US. And this is a system from a patient or from a family perspective. Healthcare systems are just one part of the systems that a patient or family is concerned with. This is a family map, family care map of a family who had a child diagnosed with cancer. I don't remember which cancer it was. But for the family, the care system is just one of the key problems to worry about. But what about education, transport, nutrition, the social system, the community? This is what really is relevant for patients. And we haven't really talked a lot about patients today. And there are, I think the discussions about patient-centered care, patient empowerment is certainly something that needs to be strengthened in this context. Why is it all relevant? Of course, we can think about making healthcare or systems more patient-centered, humane, focusing on dignity and respect, which is all crucial and important. But it also has a cost implication. If we keep on practicing medicine as we do, by paying for good medicines and drugs and training good doctors, this is not enough. Now, we have so much waste in the system. These are 3 independent projections of the contribution rates to the health insurance in Germany of 3 recognized professors. They have come to different numbers, but they all agree that the rates will go up substantially, and mostly driven by demographics and, of course, pharmaceuticals. So we need to find a way to organize systems in a better way, because otherwise, all the discussions so far today, I think, are not addressing this. We can discuss which drug to put to the basket of service or which service to improve in its organization, but we need a different approach to designing systems to make them sustainable in the future. So this is an example. It's a real person. The name has changed. She's from one of our integrated care systems. It's an 84-year-old lady suffering from heart failure, had frequent admissions to the hospital because, well, she was inadequately monitored and had experienced poor care coordination. So that's bad for the person, it's bad for the family, and doesn't generate pride amongst those that take care of the person. But going back to the previous slide, it also has a cost implication. Because in Germany, the insurance company is assigned a certain amount of money to take care of a certain person with a certain set of comorbidities, and the insurance company needs to manage with that money. So in this case, because the care is not well coordinated, the insurance company actually spends much more money than it receives. It's not sustainable, it makes a loss. So the question is, can't we do better, focusing more on efficiency, using system design thinking, and focusing more on health production, health gain? That's a different person. It's a statistical twin of the former one. And this person, same conditions, same comorbidities, same age, using propensity score matching to identify control groups. We often compare the outcome of our care coordination programs. And this person participated in a care program, got a doctor that checks on her, gets weekly phone calls, has a case manager, and the doctors participating in review boards, checking the drugs, and participating in quality circles. And this person is still independent, stays at home, contributes actively to the community, but also, if you look at the bottom, the insurance company spends less money on the person than they are assigned to. So there is a saving that could be used for further investments in health infrastructure or in the health system. So that's a key question that I'm concerned with. And I often have the feeling in healthcare we are sort of flying blind. We've got a lot of good trials, hospitals collecting great data, some GP practices doing the same. We've got some ecological data from national health accounts. But we don't really know about the quality of services. Again, if we use PROMS, we've got PROMS data certainly in some trials, but at national level, the NHS, for example, in England, collected PROMS data on 4 elective procedures. It's really interesting to see how different hospitals are doing in improving the health gains, for example, after a hip replacement. Now, previously we looked at mortality outcomes, complication outcomes. You see a little bit of noise, but basically variation, no significant outliers. If you look at the question is, can the patient walk independently 3 months after surgery, you see huge variation in the scatter plots and the funnel plots. So the question is, what explains this variation, and how can we make sure that we focus on rehabilitation and other functions in the community to actually improve value, rather than just looking at the outdated clinical indicators that we've been using for so long, complication rates, survival, and others. And cost is even worse. We have no idea about the cost of healthcare. We know how much we reimburse. We know how much we get in a hospital for a certain DRG, but we don't know how much it costs to take care of that patient. So it's really flying blind, and I think in order to make systems more sustainable, we need to get a much better understanding of both outcomes and cost in order to increase value. Even worse, sometimes we do get good data. This is from the Right Care toolkit for commissioners, so the organizations that purchase services from hospitals. And it's based on this 30, 40-year-old work on variations in healthcare. You've heard about Wenberg and the atlases of healthcare variations. Again, something we haven't really talked a lot about today. Why is it that patients with the same problem get different treatments and people with the same treatment get different outcomes? It's a huge problem in healthcare, and it's a problem that reflects a huge amount of waste as well. And this shows just a graph of comparison between clinical commissioning groups in the UK for one pathway. And you can see that there are huge variations, and the red shows that this clinical commissioning group is doing much worse than others. And the question is, who is using that data to improve the service? Again, it should be the commissioners, but they don't have the right competence. Sounds harsh, but the organizations of the commissioning boards haven't evolved around the function of purchasing for value. They're not used to that. So this data is being produced annually and causes frustration because nothing is really changing. That's another piece of work we've done in Germany, where we took a national data set of one of the largest insurance company to look at the last year of life. So we had all people deceased in that in 1 year, and looked at typical care patterns. And not surprising that towards the end of life there's a high expenditure. The question is, what generates this expenditure? We talked about drugs this morning, oncology. There's this nice indicator, initiation of chemotherapy in the last months of life. Again, I've done some research on that in the UK. Huge variations between trusts that initiate chemotherapy in the last months of life. But also questions about transport, emergency utilization. It's not generating value, because if you're in your last month of life and you're being admitted 5 times to the ER, it certainly doesn't improve your quality of life and might extend your life by 15 days. But again, if we're looking at expenditures, this is where huge expenditures occur. So what are we trying to achieve to make health systems more sustainable? I would argue, I'm in good company there, to that we need to focus on various aims simultaneously. Improving patient experience is great, improving clinical outcomes is great, improving population health is great. We need to do the three things simultaneously and even add a fourth aim to that, increasing the satisfaction of the professionals who work in the system. That's something that we certainly recognized in the NHS in the UK, where the system is under great strain and professionals really at the level of burnout, and so it's important to recognize also in health system reform strategies that we design the system in a way that the professionals like to go to work and are happy and take pride in their work. So Donald Berwick actually argued for the triple aim in his 2008 paper in Health Affairs, where he discussed how can we achieve population health. And he argues that we need three components. We need to have a clearly dedicated or a designated population, otherwise we can't talk about population health. We need a budget limit, otherwise we have an incentive to just spend more and more. And we need to have a function, a regional integrator, someone who pulls all these ends together and reduces fragmentation, uses information available to generate value, collects and invests into data systems in order to improve population health management. What are the functions of a regional integrator? I've listed a couple here that are taken directly from Donald Berwick's paper. And the question mark there on the right is just simply a question, in any system that you could think of, not at the national level, but at a regional level, who is actually in charge of this? I would argue, I haven't seen a health system where these functions are actually centralized in one function or in one agency or organization. So that's something where regional integration can really make a huge impact. But again, to make it sustainable, we need to have an approach that is not at the pity of some national funding or at the pity of some EU grant to get things running, but a system that is self-financing. And we have developed a contractual model with health insurance companies in Germany that uses a shared savings approach. Basically, the health insurance companies allow us to act as a regional integrator between them and the providers and their insurees, take care of the budget that is being assigned to the health insurance company, and if at the end of the year we can demonstrate we improved health outcomes, generated health gain, and reduced cost, then we share the savings that were achieved. It's just another slide to show the same. For such a system to work, you need to have a mechanism, a risk adjustment mechanism that takes into account the morbidity burden in the population, and you need to have a good control system to track expenditure. And if you have that, you can engage in such a contract, invest in the regional integrator function, invest in health promotion, prevention, care pathways, IT, and then share the savings for future investments. And what is really important is that once you've got such a contract, you are in an innovation space. I call it the innovation space, because you recognize there's a structure, process, outcome approach here, the old Donabedian trials of quality improvement, and you can really use academic knowledge on quality improvement and health service research or implementation science to ask yourself the question, okay, what is the burden of disease in the population? What are the service structures? How are they going to change in the future? What new technologies are there on the horizon? How could they be used? How could that be translated into processes to optimize healthcare delivery? And what is their relative contribution to health gain outcomes, economical outcomes, and patient experience? So running a regional integrator is more than what the insurance companies in Germany are doing, basically collecting money on the one hand and giving it to the providers on the other, and doing very little in between. It's really using the best clinical and managerial know-how to optimize services, because there's an incentive in the regional level to make the best out of the money available. And that incentive is in most systems not available. That's an approach that we built. So in healthy regions, which are usually small regions, we started working with population size of about 100,000. We're now moving into larger 250,000 population size. So we're talking really small regional areas where you can get to know the provider network, engage with them, and discuss the local knowledge for improvement. And then you have various pillars. Of course, you have the care programs, the clinical work, and we develop a lot of care programs for all the current chronic disease. We also focus on prevention and have a public health focus, but we also use the data for benchmarking, for reporting back to the GPs, so our GPs know how they are performing in comparison to other GPs in the area. And that, of course, you can imagine, generates a lot of debate. At the beginning, it's very hard to get this going because there's a lot of lack of trust, and it's not easy to work in such transparent system. But all the young doctors are very happy to work in such a system because they don't want to work in a single practice. They want to engage with colleagues. They appreciate sharing and discussion and learning. And so it's really a system, in our view, that is future-proof. That has been done, been implemented more than 10 years ago in the southwest of Germany. It's a contract. It starts with 1/3 of the population there, 33,000. 2/3 of all providers are now part of the integrated care network. There are no restrictions on the provider that a patient can see. It's totally open. But we identify the gaps in the system and then develop care management or case managers that help improve the care pathways for the patients. We also invest heavily in the IT. So we have an IT system where all providers can share notes, medical records, lab results, whatever. That seems to be like, I mean, I think that should be the standard, but in most cases that's not the case in Germany, that providers can access each other records. And we built a training center, which I'll show in a moment. Important, maybe I can skip this. The important issue to make this work is local ownership. So I don't go into the governance structure, which was on the previous slide, but finding a way to build local ownership into this system. Otherwise, it will be, again, a top-down approach, and it will not be effective. I mentioned the IT. You can't see all these figures there on the right. This is a performance dashboard that we give to the GPs on a quarterly basis and discuss with them. We're also opening up the patient records to the patients because they're called patient records. And when I started saying that we haven't really talked a lot about the patient this morning, we do a lot of modeling. And we modeled that the patient is the biggest resource we have in the system. The effects that we can get through patient activation are likely to be much more than we get from any vaccine or, well, I leave the vaccine over, from any other drug and any other therapy. So patient activation is a key issue. We also do a lot for healthy people. So this is a quote from Ilona Kickbush, who I'm very pleased to say she's one of the global thinkers of health promotion. She's in our advisory board. And she argues that health is not a function of what we do in the health system. Health is created in all systems, in education, in schools, in transport, and we need to try to reach out through these other sectors and address the determinants of health if we really want to have a lasting impact on health outcomes. And that's a training center where we offer courses for elderly people, but also for young people. We go to schools, we offer advice on overweight, obesity in children. So it has a strong public health focus. And this is just a financial effect that we've observed in the last years. So on a population of 33,000, there are 5.5 million savings every year, and that is used to pay for the services that we're providing, the prevention focus and care management and IT. There are also some other outcomes that we achieved. Actually, people that have been assigned and have been followed in this integrated care network have now an increased life expectancy. They live a year and a half longer, while at the same time having a lower burden of disease. So they have less nursing needs. So it's a compression of mobility that we are actually observing. I've addressed the financial impact, and the satisfaction rates of patients are extremely high because at any time they have a navigator, they know how to access the system and can make best use out of it. This is another project that we started in Hamburg, in the north of Germany. The colored dots actually show the average age at death. So you see the green dots, which are the affluent areas where people die on average in the late 80s. You've got the yellow dots, and then the red dots, which are the deprived areas. And there's a 13-year difference in the age of death within one city in Germany. And we felt that was not acceptable. I'm not sure if you can see it, there are small black dots all over the map of Hamburg. The black dots are indicated where the doctors are. So the doctors are in the affluent areas. And the red dots, you see, there are very few black dots around the red dots. So it's an issue of inequality, and which is reflected in the huge differences in life expectancy. And one thing that we started doing, just opening a health kiosk last month, which is modeled after the Finnish example of a health kiosk, where anyone can come in, irrespective of health insurance, get advice on lifestyle issue. We have nurses there, we have midwives, nutrition advisors, and we help patients navigate the health system, which is a huge issue in that neighborhood because 70% of the people have a migrant background. That is not necessarily the first generation migrant, it might be a second generation migrant background, but still they have problems understanding the complex German systems or understanding the German forms, the paper forms that are sent out. I have to read them 3 times to know what really is requested. So imagine someone from a lower educational background who doesn't manage the language. So that's a huge success, a health kiosk to help the community navigate the system.
Maybe your conclusion?
Yeah, this is the conclusion. It's a German model, but has been published widely internationally already. There's some other areas where we work in and countries. These are my contact details. I think the conclusion is really in the title. I'm convinced that we do need to continue discussing health systems and policies, and that's very clear. But there's a mesotier function, which in most health systems is currently missing, which is the regional integrator. And that's my conclusion, that we need to discuss or think how can we establish such a regional integrator to work for smaller regional populations to optimize services and then work towards the AAA.
Thank you very much. Myself, I like very much the holistic approach on health, and that the answer to some of our challenges in the health sector, it's integration at community-based or regional level of the health services. I was wondering if in Romania we'll try to implement such a model. Maybe we'll start the contest for the position of chief medical officer at regional level, and because every time when such development may be put in place, we find alternate solution to this, not the right one, and I think we have a little thing to this. Okay, I invite you to take a seat here in the yes.
Just want to, I'm very impressed by this, also by what you presented. And you were very right to return from the issue of the vaccination, but for me vaccination is part of the primary prevention. And just remember, you talked about how to best manage a patient. Primary prevention prevents a person to become a patient. So actually, my goal as a person who is interested in vaccination as part of the primary prevention is to make you workless. And so the idea is that those two things are going in parallel. It's not that one is better than the other. You actually, the more you prevent patients, the more I enable you to appropriately treat the patients, because you have less of a load.
Can I just respond? I absolutely agree with you, but I think it wouldn't make the region integrator out of work, because there's always a potential for health gain.
We will never be completely healthy until we die.
Yeah, exactly, exactly. Let's leave.